Welcome to the Radiology Review podcast, your on-the-go source for radiology education with your host, Dr. Matt Covington, a board-certified radiologist. Please follow the podcast on Twitter at RadRevPodcast. Send emails to theradiologyreview@gmail.com or visit the website theradiologyreview.com.
Welcome back to the Radiology Review podcast, your on-the-go source for radiology board review. On this episode, I will be presenting what may be the most requested topic I have had to date, and this topic is Name That Nuclear Medicine Scan. For those of you that are in the midst of ABR core exam study, you know the classic question that requires you to name the nuclear medicine scan or radioisotope simply by looking at an image. You also know that these types of questions can be tricky, so on this episode I will present in question and answer format various tips and tricks to help you correctly identify nuclear medicine scans that are commonly tested on these types of questions. Before we get into the questions and answers, I want to give another shout out for those of you who are looking for additional resources to help you prepare for the ABR core exam, to check out the ABR board review community on Discord. I will have a link in my show notes, and this is a community of over 400 residents and over 60 radiology faculty members. It is a place where you can ask questions if you encounter a question that you're unsure about. It's also a place where you can find content such as many cases others have posted and discussed that may be helpful to you as you prepare for the ABR core exam. Also, a shout out to Radiology Cord, that is CORED, at the website radiologycord.com. This is a free online question bank that I have checked out, and based on the questions I have personally seen, this looks like an online QBank that is testing what I consider to be high-yield areas for radiology board exam in an easy-to-use interface, and best of all, it is free. So if you are looking for more QBank questions, go ahead and check out radiologycord.com. And as a reminder, I am not compensated in any way by either of these sites, so I have no interest in telling you about these other than to simply present a few online resources that some of you might find helpful for your ABR core exam, ABR certifying exam, or other radiology exam preparation. That's enough talk. Let's get into the questions and answers. First question: what are some basic ways to tell between a general nuclear medicine scan? And when I say a general nuclear medicine scan, I mean nuclear medicine scans that use gamma cameras versus a PET scan. How can you tell the difference just by looking at an image in terms of whether an image came from a gamma camera or if it is a PET scan? Probably the most obvious answer here is that PET scans are of simply higher image quality and resolution, and by simply looking at the images, typically you can tell a PET scan from the more noisy, more count-poor general nuclear medicine scan with a gamma camera. Additionally, if they show you a maximal intensity projection image or a MIP image, that is a clue that it is a PET scan. If you are shown a planar image, that means you are looking at a general nuclear medicine scan. One word of caution: fused images can come from either a gamma camera using SPECT CT, that is SPECT, SPECT CT, or PET CT. You can have fusion images between nuclear medicine and CT with either SPECT CT or with PET CT. So fusion alone does not mean that it came from a PET CT or even a PET MRI system. It could be a SPECT CT or a software-fused SPECT MR image. Next question: what type of general nuclear medicine scan is characteristic on board exams for having a super hot spleen? The answer I am looking for here is a tagged white blood cell scan. Let me take a moment to say that I am well aware that for some of these questions, potentially there is overlap with other scans, but I'm simply trying to help you on ABR core exam multiple choice format questions to get the correct answer. In reality, some of these scans and issues are a little bit more complicated than I'm presenting here, but again, my goal here is radiology board exam preparation. So on a multiple choice exam, if they show you an image and it has a super hot spleen, the first exam to consider in my mind would be a tagged white blood cell scan. As a reminder, a tagged white blood cell scan can either be a Technetium 99M tagged white blood cell scan or an Indium 111 tagged white blood cell scan. There are two flavors, you could say two varieties of tagged white blood cell scans. Technetium tagged white blood cell scan may be performed in kids because it has a shorter half-life, which means a lower overall dose exposure, and it provides higher quality imaging, especially of smaller anatomy. So for kids, a Technetium tagged white blood cell scan may be preferred, especially on radiology board exams. On the other hand, an Indium 111 tagged white blood cell scan offers the advantage of several things. First, Indium 111 with the longer half-life allows for more delayed imaging to be performed. Indium also has less bowel uptake, so an Indium white blood cell scan is best for inflammatory bowel disease evaluation, another classic board preparation point. Other radiotracers that have a really hot spleen include an octreotide scan that can also have a hot spleen but generally has more counts and will look like a higher quality study. And an octreotide scan also has very robust kidney uptake and absence of bone uptake. If they show you a tagged Indium 111 white blood cell scan with really hot kidneys, you should consider pyelonephritis or other causes of renal inflammation. That may even include things like renal toxicity from chemotherapy. To summarize, Technetium white blood cell scan commonly will present you with 4 and 24-hour imaging. At 4-hour imaging, you have less GI activity. At 24 hours of imaging, you have less lung uptake. And a Technetium white blood cell scan would show both GI and renal activity. An Indium 111 white blood cell scan would typically have no renal or GI activity, or at least very low renal and GI activity, and is also a lower count study due to the fact that this has a longer half-life, and therefore you simply cannot inject as much of the radiopharmaceutical into the patient in order to maintain acceptable radiation doses to the patient. And Indium 111 also has less optimal energies for gamma camera imaging compared to Technetium, so it has a lower quality appearance that appears count poor and more noisy compared to Technetium. Those are some very important points I just discussed. Let's move on. For whole body iodine scans with I-131 or I-123, what is the expected uptake in the liver, in the heart, and in the bones/bone marrow? Expected uptake for an iodine scan, whether I-131 or I-123, is as follows. First of all, you are not expected to have uptake in the heart, in the kidneys, or in the bones or marrow. Liver uptake is not present typically on a pre-treatment iodine body scan, but can be seen on a post-therapy iodine scan without necessarily denoting metastatic disease, especially if you see diffuse liver uptake. You can have some slight gastric and bowel uptake, so keep that in mind. A little bit of gastric and a little bit of bowel activity on an iodine scan is usually normal, and my understanding is that that is due in part at least to salivary secretion of iodine, and you also have normal nasopharyngeal uptake. Of course, on an iodine scan, you also expect thyroid uptake, as well as uptake in any potential sites of thyroid cancer metastases that are not dedifferentiated, meaning that you would see uptake in any site of metastatic thyroid cancer in which those thyroid cancer cells have retained their ability to take up iodine. That brings us to the next question. What is the next step if you see a negative whole-body iodine scan in a patient with history of thyroid cancer who also has a rising, elevated thyroglobulin level? The answer here is that you want to get an FDG PET-CT scan. You have to be concerned for dedifferentiated thyroid cancer, meaning that the thyroid cancer cells can no longer take up iodine because they have dedifferentiated. Thus, your iodine scan would be negative, but with a rising thyroglobulin level that is elevated, you know that thyroid cancer cells are back somewhere. If you don't see them on the iodine search, you then need to go on and get your FDG PET-CT scan because these dedifferentiated thyroid cancer cells are aggressive and glucose hungry and thus FDG avid. Next, what are key features of a gallium-67 scan? A gallium-67 scan is the general nuclear medicine gamma camera variant of gallium, whereas gallium-68 rhymes with dotatate, and that helps me remember that that is the PET agent. On a gallium-67 scan, the first thing I think of is lacrimal gland uptake. Now, it is not the only tracer that shows that, but it is a very classic one. And if I see a lot of lacrimal gland uptake, I immediately need to ask myself, is this a gallium-67 scan? Additionally, with gallium-67, you would expect bone uptake, and you would expect lack of splenic and renal uptake. Gallium-67 scans are typically count-pore studies because you have non-optimal energies for gamma camera imaging. As a reminder, those energies are roughly, not exactly, but roughly 100, 200, 300, and 400 keV. And with gallium-67, you have a very long half-life of 78 hours. And that means because of the long half-life, the injected dose needs to be lower than with something like technetium that has a shorter 6-hour half-life in order to minimize radiation exposure to the patient. A key point for all nuclear medicine studies is that the shorter the half-life is, the higher the dose that can be safely injected because that dose will quickly be gone within the body, and the higher quality the imaging will therefore be. Longer half-life radiopharmaceuticals generally result in count-pore studies because injected doses have to be lowered in order to maintain acceptable radiation exposures, and typically these longer half-life agents also do not have optimal energy for gamma camera imaging. They are good enough but not optimal, and the imaging quality is lower. Next, beyond a gallium-67 scan, what other general nuclear medicine scan can demonstrate hot lacrimal glands? The answer I am looking for here is technetium 99M per technetate. That is the exact same thing as free technetium. You can distinguish free technetium or technetium per technetate from a gallium scan because it will be a higher count, higher quality study, and it will show some splenic uptake as well as renal uptake. Next, what areas are expected to show physiologic uptake on a sulfur colloid scan? A sulfur colloid scan has expected uptake within the bones, and I remember this because sulfur colloid scans are used for bone marrow scan evaluation. For example, when you combine a technetium or indium white blood cell scan with a sulfur colloid scan, the sulfur colloid scan will show you the normal distribution of bone marrow uptake, and that can be correlated with uptake on the white blood cell scan. And for areas of infection, you would expect displaced bone marrow, therefore lowered sulfur colloid uptake with increased white blood cell uptake in that region. Sulfur colloid is a very versatile and inert nuclear medicine agent, so it is used for many imaging studies. But one key characteristic is that you will see bone uptake from that uptake within the bone marrow. Additional characteristic features for sulfur colloid is splenic uptake that is roughly equal to hepatic uptake, or sometimes the liver is even slightly above the spleen. There is something called the colloid shift that derives its name from the sulfur colloid imaging scan, and a colloid shift means that the spleen has more uptake and is often larger than the liver. And I told you previously that usually uptake in the liver is higher or equal to that of the spleen. So if you see the opposite pattern, the shift in the colloid scan uptake pattern, that means that you have increased portal venous pressure. The normal colloid pattern has shifted towards increased splenic and sometimes bone marrow uptake, and this is a sign of portal hypertension and often end-stage liver disease. With colloid shift, the spleen is also often bigger than the liver. So remember, sulfur colloid scan, look for three things: bone marrow uptake, liver and spleen uptake, and with normal physiologic uptake in a healthy person, the liver activity will be equal to slightly above that of the spleen. Next, what are characteristic areas of uptake on a free technetium scan? As another reminder, a free technetium scan is also a technetium 99M per technetate scan, and it is called Freetech because usually in nuclear medicine we image technetium bound to some other pharmaceutical, but if it is simply injected in its pure technetium 99M form, that is technetium per technetate, it is free from binding from anything else, and therefore free tech. Free tech can either be intentional, such as with a Meckel's scan, where you are looking for ectopic gastric mucosa within an abdominal or pelvic Meckel's diverticulum, or free tech can be a contaminant due to incomplete binding at time of radiotracer preparation or after injection. And it is important to be able to identify when free technetium is present. If you see salivary gland, thyroid gland, and gastric uptake, those are all key signs that free technetium is present. The classic imaging scenario is a tagged red blood cell scan, in which if you see uptake in the stomach, you need to be cautious to say that there is a gastric bleed until you have imaged the head and evaluated whether you also see salivary gland and thyroid uptake. If you see diffuse or prominent gastric uptake on a tagged red blood cell scan and you image the head and neck and there is no uptake, that tells you this is not free technetium, but that is actual bleeding. And you can go ahead and say there is gastric bleeding on the board exam question. However, if you image the head and neck and you see uptake in the thyroid and salivary glands, you need to say, hold on, there may not be a gastric bleed here. This is probably free technetium. I hope that makes sense because it's a very important concept for radiology board exams. Next question. How do you tell a fluorine 18 F18 sodium fluoride PET scan from a technetium 99M MDP bone scan? In both of these scans, because they are both forms of bone scans, the areas of uptake will be similar. You will see uptake predominantly within the bones, with some renal and soft tissue uptake as well, unless it is a super scan. However, the F18 sodium fluoride PET scan will look much higher quality than the MDP bone scan. Really, it is that extra quality and detail that you can see on a sodium fluoride PET scan that clues you in that this looks simply too good to be a technetium 99M bone scan. And if you have not seen what I'm talking about yet in real life, go ahead and Google images of sodium fluoride PET scans, and then Google images of technetium 99M MDP bone scans, and see for yourself how the PET scan looks like a much, much higher quality study than the technetium bone scan. That is it for now. I will present part 2, which will continue this review of nuclear medicine Name That Scan on the next episode. Keep up the good work. I hope this was helpful for those of you preparing to take the ABR core exam. Keep studying hard. Remember, you do have to study really hard to succeed on that exam, so prepare to succeed. I will catch you on the next episode. Content of this podcast is provided for informal educational purposes only for radiology trainees and radiologists. Medical practitioners, please make your own independent assessment before suggesting a diagnosis or recommending any course of treatment. This podcast should not be used for self-diagnosis or self-treatment and is not a substitute for independent professional medical care. Please consult your own physician regarding any diagnosis, imaging interpretation, or course of treatment.